here at Project Echo. And again, this is a presentation originally created by Dr. Maley and myself, and also Dr. Jacobson and Clark. None of us have any financial relationships to this program, either in the past or in the present. So starting with that disclosure, let me just actually minimize this screen. Talk about opioid use disorder treatment and its barriers. So this is sort of the overview talk, and in light of recent data, we just revised it within the last couple of months for the last cycle, so about 3 months ago. So the data presented here is up to date. So we're going to summarize some key findings of reporting of the national opioid overdose epidemic and describe how they inform clinical practice. We'll talk about what's recommended and what's not recommended briefly. When I talk about treatment for opioid use disorders and identify some barriers to treating opioid use disorder in personal clinical practice. Starting with an epidemiology, right? I think as all of us are aware at this point in 2020, opioid use disorder is an epidemic. And there is a lot of stuff coming out, right? That as we deal with the pandemic of SARS-CoV-2, COVID-19, opioid epidemic has not only continued to simmer, but in many ways sort of get more severe, more worse, and some of that data is starting to come out. So really we've been dealing with kind of two epidemics that are intersecting with each other and are leading to a major public health challenge. So this slide you may have seen before, right? So this talks about how the opioid epidemic really hit us in multiple waves. The first wave really is the purple line, which is the commonly prescribed opioids, such as oxycodone, such as hydrocodone. Even starting in the 90s, right? Physicians, prescribers started prescribing these medications more liberally as we became aware of pain and how important it was to treat pain, and pain became the fifth vital sign. Along the way, sort of this idea that especially long-acting opioids were somehow safer to prescribe, which we now know is not true. Right? We started prescribing them more liberally. And even as early as the early 2000s, some of the data started coming out, showing that emergency department visits related to overdose of these opioids, prescription opioids, had risen fairly dramatically. For example, it was reported in 2003 that in the previous 7 years, emergency department visits related to oxycodone had gone up 450%. And they had doubled again between 2003 and 2009. So they continued to rise, and correspondingly, we started seeing pretty dramatic increase in overdose fatalities associated with prescription opioids. As we started realizing it, we started placing more of an emphasis on education, right? Also, legislation started getting passed. Naloxone prescriptions started picking up, and we started seeing some plateauing of overdoses related to commonly prescribed opioids, right? Our prescription opioids. But unfortunately, around the same time, starting in about 2009, we saw a dramatic increase in overdose fatalities related to heroin. In fact, between 2009 and I believe 2016, overdose mortalities associated with heroin went up 600% or sixfold. And then more recently, we've been really grappling with something even more challenging, which is this kind of this black line, the blackish purplish line, right? Which is our fentanyl and fentanyl over analogs. Starting in about 2013, we really started seeing a rise in synthetic opioid overdose mortalities. And in New Mexico, it's been slower, but even in New Mexico at this point, we're starting to see a rise in overdoses related to fentanyl and its analogs. So kind of going forward a little bit, and this is kind of more recent data, right? That overall, drug overdose deaths went down marginally between 2017 and 2018, but it was still 4 times higher in 2018 than it was in 1999. And the majority of illicit substance overdose mortalities involve opioids, right? And these are just some trends from 2017 to 2018. Where you can see that while prescription opioid involved death rates continue to go down, you are seeing an increase in synthetic opioid death rates. primarily fentanyl and its analogs, as I just talked about. And those are continuing to go up, and they've been a major challenge. And this is New Mexico data. Most common drugs involved in unintentional overdose deaths, prescription opioids lead the way at 46%, followed by heroin, followed by methamphetamine, which has been rising quite rapidly, followed by benzodiazepines, followed by cocaine. And you might point out that they add up to 100%, greater than 100%. And of course, the reason for that is that very often we see these substances coexist, right? When you do overdose postmortem analysis. Kind of going forward, so what are some of the adverse outcomes associated with opioid dependence, with opioid use disorder? So the natural course of opioid use disorder is quite detrimental. You can see hepatitis C is a major finding, major comorbidity that we see. We know that at least 70% of injection drug users are hepatitis C positive, and it's been shown that even after just a year of injection use, about 65% of individuals become hepatitis C positive, and that number rises to over 85% after 5 years of injection use. Same with HIV. Injection users account for at least a quarter of all new HIV infections, and there is some data showing that that number has been rising, and HIV is found in about 20% nationally of all drug users. So significant comorbidity. Of course, we've talked about overdose mortalities. Hold on 1 second. And some of the major causes of mortality can include things like drug overdoses, suicide, violence, accidents, infection, and of course, chronic illnesses. And then there is a variety of psychosocial risks, right? Individuals who have developed a substance use disorder, opioid use disorder, it may be hard for them to find and maintain employment, right? And a lot of it has to do with this cycle of addiction, right? Where, for example, if I developed an opioid use disorder, I might be going into withdrawals several times a day. So how can any of us maintain productive employment when we're either in withdrawals or worried that withdrawals are going to be striking pretty soon and finding a way to prevent withdrawals or come out of withdrawals? We easily take over sort of our lives. And oftentimes the crimes are related directly to that opioid use disorder and can be very common. And ultimately, the cost to our medical system is also quite high when opioid use disorder is left untreated. One of the things that we know is that the natural course of opioid use disorder, if left untreated, is one of loss of health, loss of employment, loss of meaningful relationships, right? Loss of family, loss of freedom, and if left unchecked, unfortunately, all too often, loss of life. And I think that's where our opportunity comes in. Can we intervene? Can we come in and hopefully try to break this cycle? So some treatment perspectives and considerations, right? Going forward. Over our history, substance use, misuse has been viewed and treated differently. Addiction is a crime. Unfortunately, even in 2020, this is a perspective that persists, right? Viewpoints that have focused on the impact of use on society. And especially in the United States, I think there's a long, rich history of addiction being treated as a crime and or as a moral problem or failing, right? If you think about sort of how addictions treatment, substance use disorder treatment emerge, its roots are often in the temperance movement, right? And sort of preachers in the Appalachia kind of roaming from community to community, talking about how this was a moral problem failing and using spirituality as a way out of it. And often these two have become sort of entangled. And even more recently, we see this as war on drugs. I think it's been said that language matters, right? And when we talk about war on drugs or declaring war on drugs or substances being a criminal problem, the resources we mobilize or dedicate towards a substance use disorder are often going to be incarceration, right? Law enforcement as opposed to treatment. So I think this is a pretty important thing to point out. There is also the idea of addiction as a disease, the viewpoint that drug use is caused by a disease process, cause and effect relationship. And then finally, something that I think many of us would agree, addiction as a complex, multifaceted condition. The viewpoint that addiction, it's not just one thing, but it is psychological, physiological, social, environmental, and I would say even spiritual contributors. And it's ultimately the greater than sum of its parts. And when it's been established, when it's been set in, it can impact every aspect of an individual's life, as well as their families and communities. Right? So ultimately, it's a complex biopsychosocial process. Biologically, we know, and there is data going back decades, that drugs ultimately alter the chemistry of the brain and body functioning. Continued use can cause damage or injury to vital organs, as well as neurochemical processes and structures, to a point where the individual who has developed the substance use disorder comes to see that substance as being necessary for survival. And all efforts, or majority of efforts, are geared towards surviving. Psychologically, altered brain chemistry affects the brain's ability to think, alters feeling states, and impacts the perception and behavior of the user. Often after chronic use, this state emerges where the person doesn't feel good. There is high anxiety, there is high depression, there is little pleasure, and the quickest way to alleviate those feelings is by using the substance. And sociologically, behavioral interactions with family, social contacts are altered and or misinterpreted by the user, and those observing the behavior resulting in systematic feedback loops that reinforce this use, right? And it sets up, unfortunately, a vicious cycle. We know that substance use is multifactorial, substance use disorders. About half the contribution roughly comes from biology and genes, and about half the contribution comes from environment, which, as I'll point out, and as you may know, is very similar to our other chronic diseases such as diabetes, hypertension, and asthma. It is important to point out that, like with all chronic conditions, substance use disorders and opioid use disorders, also it's possible to achieve recovery. And the process of change through which an individual achieves in improved health, wellness, or quality of life is really that journey of recovery that we talk about, and may or may not include sobriety, right? I think recovery as a concept really talks about reclaiming the life, including physical health, psychological health, a sense of purpose within your community, meaningful social interactions, stable housing, right? Stable health, and doesn't necessarily include complete sobriety. There are lots of similarities, as I pointed out, with other chronic illnesses. We know, for example, that genetic impact is similar. With all of these things, about half the contribution is genetic, and the other half comes from environment. And medication adherence and relapse rates are also similar, and therefore, long-term maintenance treatments have been proven to be the most effective. Simply doing an episodic treatment is much less successful. And this is just one of the slides showing relapse rates. And we included this slide because there is often this idea that people with substance use disorders, it's hopeless, that they'll never improve, they'll never get better, that they're always going to be relapsing. But you can see that relapse rates for drug addiction is actually quite similar to the relapse rate for individuals with hypertension, asthma, as well as type 1 diabetes. And stigma plays a major role in recovery. We have effective treatments. We know what works. We know what's effective. However, individuals with substance use disorder continue to be perceived as having moral weakness, character flaws, and being untrustworthy or criminally involved. And these are just sort of, something to reflect on. Ask yourself if you have ever had any of those thoughts about your patients, right? I think it's important for us to think about our own stigmas, our biases, so that we don't have those blind spots rather, when we work with our patients. Medical professionals continue to view addiction negatively, right? An example, a recent study on medical perspectives found that responders said people with substance use disorders should receive less priority in healthcare, that their condition was their fault. And imagine what our lives would be like if we were faced with this stigma day in and day out. And we know that individuals with substance use disorders internalize that stigma. And when that stigma gets internalized, outcomes get worse. They're less likely to seek and stay in treatment because they may feel shame or worthlessness. There's worse mental and physical health. There is decreased employment and decreased housing, disenfranchisement, feeling marginalized, poorer support systems, right? This increasing isolation. And we know that isolation is not good for people struggling with substance use disorders. And ultimately, there is a sense of learned helplessness. Why bother? Yeah, because there's this idea in the society, quote, once an addict, always an addict. And ultimately, outcomes are affected. So what are treatment recommendations? We'll start with the general recommendations. As in all chronic illnesses, treatment should be continuous rather than episodic and focused on the whole person, not just their use behavior. Treatment should include a combination of medication, learning new skills, social support, and chronic care management. Goals should be improvement, not cure, because relapse or episodic use is the rule and not the exception. I like to point out that there is, especially with opioid use disorders, there is data that shows that, say you have an individual in treatment, they're doing well, they're in remission, and they have a recurrence of use, they wind up using. There is data that shows that if you can engage that patient back in treatment, the subsequent episode of remission tends to be longer. So one of the things I like to view is that a relapse or recurrence of use is an opportunity to get the patient to do even better, as long as you can engage them. And often we do this by keeping an open door, being non-judgmental, seeing the patient's perspective. What can we do to help you again? Using evidence-based treatments leads to substantial improvements in reductions of substance use, increases in personal health and social functioning, reduction in threats to public health and safety, as well as reduction in monetary costs to the individual and the community. So treatment works, right? And recovery requires active work across all dimensions of wellness, including health, emotional and physical, stability and quality of family and peer relationships, right? So peer support workers, for example, can play a huge role. Community advocates, grassroots levels advocates can play a huge role to create an environment where the person does not feel isolated. Comfort, stability of living environment. And this is something we can be doing a lot better, creating things like, housing first programs, allowing for stable housing, positive community participation, right? Monitored work setting, volunteering, giving that sense of purpose ultimately allows for life meaning and purpose, which are all essential components of recovery. And this can be a lifelong process. So I'll start with some psychosocial interventions, things we know that work. So first, this idea of harm reduction versus abstinence, right? There is, and historically, a lot of attention has been paid to the abstinence model, right? Which has been around for, close to a century, which assumes that abstinence is the best and most effective way to treat addiction. AA and 12-step, for example, adhere to the abstinence model. There is also the Minnesota model, which has been used in a lot of our inpatient drug treatment centers. And then there is the harm reduction, kind of what's called the warm turkey model, which has really emerged in the last 3 decades or so, where the priority is placed on reducing harm, social, health, economic of substance use disorder. Again, the idea is that substance use disorders are similar to other chronic health issues. And how do we minimize harms? How do we allow an individual to live a fuller life, to reclaim their life, to be well? How do we support them with their well-being? And complete abstinence may or may not be a component of that. Users can be in treatment while continuing to use, and medication and replacement therapies are encouraged. And we try to match treatment to where the individual is in terms of their readiness to change. For example, if someone is pre-contemplative, they're not ready to stop using, then one of the things that we know works really well is motivational enhancement. Working with the patient. How do we increase your motivation to reduce your use, or maybe to reduce harms associated with the use? If someone is in the preparation stage or contemplation stage, they're ready essentially to stop using, right? Then we try to match them to appropriate treatment. And if they're already working on it, if they're already in action or maintenance stage, then we often work on things like relapse prevention, relapse management, right? Things like that. Outdated perspective that patients have to be ready for treatment, right? There's this old idea that you have to hit rock bottom. There is nowhere to go but up before you can be ready for treatment. But we know that's not the case. Even if someone is not ready, there are many evidence-based things we can provide to hopefully work with them until they are more ready. So what are some things that are not recommended ineffective intervention. Detox alone has never been shown to work with opioid use disorders. If you simply detoxify someone and don't provide ongoing treatment or interventions, you are not improving outcomes. I like to use the example of someone with diabetes, right? Say you have an individual with diabetes and they develop diabetic ketoacidosis, right? If we apply the detox alone model to this, this is what it would look like. The person with diabetes develops ketoacidosis. They go to the hospital. They stay in the hospital for maybe 3 days. You correct their electrolytes, you correct their blood sugars, and if they're lucky and they have the right insurance, and if they live in the right part of the state or the country, and if beds are available, then maybe they go to a 28-day unit for quote unquote diabetics, where they learn to eat healthy and exercise, and then they're discharged right back to their home without any ongoing support. Can we imagine that? We can't, right? I mean, it sounds so unethical and so medically inappropriate, and yet we continue to apply this model to individuals with opioid use disorders all too often, even in the 21st century. Individual psychodynamic or psychoanalytic therapy only has not been shown to work with opioid use disorders. Same with unstructured supportive individual therapy, unstructured process-driven group therapy, unstructured being the keyword, discharge from treatment in response to relapse or ongoing use, something else that I see disturbingly too often. I come across settings where they have a 3 strikes and you're out rule, where if the person in treatment tests positive for a substance 3 times, they're discharged. We know that outcomes get worse when we discharge people administratively. Mortality goes up exponentially. So we should not be doing that. We should be doing everything we can to retain the individuals in treatment. Confrontational approaches are not shown to be successful for most people. Acupuncture alone, again, acupuncture can be a great supportive modality, but by itself has not shown to be helpful. Same with relaxation therapy alone. Biological monitoring, UDS only. So what are some evidence-based interventions? Motivational interviewing, enhancement therapy, both individual and in groups, right? And especially helpful for people who are kind of in those early stages of change. Cognitive behavioral therapy, again, individualized and group, which includes harm reduction, relapse prevention, contingency management, which enhances the incentives for someone to not use substances or to engage in treatment. Extremely effective across substances, across treatment setting, across age groups. It doesn't seem to be used enough. Community reinforcement approach, again, both individual and group. 12-step and peer support programming can be very helpful, but I think it can be tricky because unfortunately many individuals, especially the ones who are maintained on the medication, can find they don't get the acceptance they need. So I often tell people to kind of try out a few groups until they find one that resonates with them, that works well with them. Structured family and couples therapy can be very helpful, and very helpful especially in our youth, right? Because it allows them to strengthen their family and social support system. And medication-assisted interventions. And this really over the years has been changing when we talk about opioid use disorders, where medications now have come to be seen as being the centerpiece of treatment for individuals with opioid use disorders. In fact, increasingly, instead of medication-assisted treatments, we're calling them medications for opioid use disorders, or MOUD, or medication-based treatments. So the terminology has been changing to reflect increasing evidence showing that medications are essential for most people with opioid use disorder. Of course, we have 3 FDA-approved medications, and all of them are effective. They include methadone, buprenorphine, as well as naltrexone. Buprenorphine in Europe has been used really since the 1980s, but in the United States has been used since the early 2000s, where the Drug Abuse Treatment Act made it possible for office-based prescribing of buprenorphine to treat opioid use disorders. In 2020, if you're MD or a DO, if you're a physician, you're required to have an 8-hour special training, which then gets you an X number to prescribe buprenorphine. There is federal legislation that would do away with this, which I think would be a major public health step forward. But right now that's required. And most providers can go up to 275 patients eventually. And Ps and PAs now can also prescribe buprenorphine after a 24-hour training. And more recently, this privilege has been extended also to our CRNAs clinical nurse anesthetists, nurse midwives. We're expanding the pool of people who can prescribe buprenorphine. And yet, significant treatment barriers exist. This is kind of the last point I want to make in today's talk. We know these medications are effective. Buprenorphine in theory can really improve access, and it has to a degree, but barriers remain. To psychosocial treatments, 77% of US states have unmet behavioral health or addictions needs, and this tends to be even more prevalent in rural states, such as New Mexico, right? 2.5 million individuals received addictions treatment in 2013 out of 22.7 million who could have benefited from them. So you can see what a large gap exists. Again, lack of mental health providers in general is a major reason, and even greater lack of behavioral health providers who are qualified to treat individuals with substance use disorders. Also, stigmatization of the substance abuse field. I don't work with those people. We come across this a lot. Limited understanding of evidence-based models, right? So more education can really help with this. Also things like low compensation, high turnover, high burnout rates. And SAMHSA really has recommended to disseminate training, to educate, to build up the workforce, also to increase the number of peer supports, which can be amazingly helpful, and develop ways to track behavioral health workforce and to fund workforce needs. With methadone, there are lots of treatment barriers. By law, it can only be prescribed from an opioid treatment programs. So it's out of the medical mainstream. There's stigma of specialized methadone clinics. Location of clinics. There is still one state that doesn't have a single clinic. And even in New Mexico, there are regions of the state with no close-by opioid treatment program. Also, requirements for daily dosing can be quite stringent and interfere with someone's ability to participate in treatment. So again, in theory, office-based treatment with buprenorphine or naltrexone can be extremely beneficial by really allowing and increasing access. But yet, lack of availability is a problem. I'll start with some good news. So nationally, especially as our NPs and PAs have started prescribing and getting their X waivers, the number of waivered providers has gone up 175%, right? And patients' capacity has over doubled just in a 3-year period. So that's really good, but still there are some concerns. Still, about a third of US counties don't have a waivered provider, but that number is 57% when we talk about rural counties. New Mexico has actually done very well, where most of our counties have at least one provider prescribing buprenorphine, but as those folks from New Mexico know, we still have a long, long way to go. And 20 million individuals live in counties without a buprenorphine waivered provider, and over 70% of them are actually in rural counties. So especially in rural America, access to buprenorphine is a particular concern. And in this map, all the regions of the country which are white are regions with not a single buprenorphine provider. The ones with blue have both a physician and a nurse practitioner. The ones with green have a physician only, and the ones with red have a PA or an NP only. So you can see that kind of that whole kind of tornado belt, I guess, in the middle of the country especially has a long, long way to go. And I will end it here. It's about 10:35.